Welcome back to Cath Lab Outreach. My name is Scott. Today we're going to talk about implantable pacemakers and defibrillators. So here's an example of a pacemaker and a defibrillator. Pacemaker there on the left side. How much smaller this is. Now both of these are older technologies. These are samples that we have I use for teaching. But the pacemaker is a much smaller dimension. And as battery technology improves, and the technology for the controlling these things improves, they're getting smaller and smaller. Defibrillators are much larger because they have to generate a lot more energy over time to be able to defibrillate a patient several times over several years. So that battery is much larger. You're also seeing things called biventricular pacemakers and defibrillators, which also the proper name is CRT, cardiac resynchronization therapy. And we'll talk a little bit about that as we go on. Medtronic's Micra is a leadless pacemaker and actually gets implanted in the right ventricle. You can see with the caliper is a little dimension, about 25 millimeters in length. And in this demo, those are just rubber barbs, but normally those are steel barbs that come out and they ride in the catheter. And as they come out, those teeth peel out and dig into the muscle. And they want to get enough connection with that. And that's actually the connection that it'll make for the pacing. And we had this the other night where a patient came in and said they had a pacemaker, and you're palpating, you're feeling that chest, and like I don't feel anything in here. You see a scar where one had been. It turned out it was a leadless pacemaker. So you get all the effects of your pacing, but you don't necessarily have to have any scars. That person had one removed, but a lot of patients get this as their only pacemaker. Here are leads that are used for pacemaking and defibrillating. Over here on the right side, that top one, you'll see that long silver area there on the blue. That's actually your shocking coil. And you can see here, this is called an active fix. There's actually a helix that comes out and we'll actually screw that into the heart muscle. So implantable cardioverter defibrillators, ICD. I remember the first time I heard that, I've been in EMS and fire for a long time. And, cardioverter, that's not even a word. Someone just made this up. Well, that's actually what it's called. So when you talk about an ICD, you're talking about an implantable cardioverter defibrillator. And these have the ability to anti-tach pace. We'll show you that, to defibrillate in the pacemaker. All ICDs can pace. So if I suffered a cardiac arrest, just a sudden cardiac arrest, I have no other problems. My ejection fraction's good. I don't need anything else. I just have suffered cardiac arrest and VFib, VTAC specifically. Then I qualify for a defibrillator. Well, that pacemaker may just be set to 40. I'm active. I'm able to get back in shape. You'll see this with young athletes. That defibrillator is going to be used to protect a patient like that most of the time, but the pacemaker part doesn't need to be set very high. So that way the patient can get trained, their heart will stay responding to their own conditioning and can go down very low. A lot of those athletes will have heart rates less than 40, but this one will not let the patient's heart rate go below 40. So all defibrillators can pace. So criteria for this is ejection fraction less than 35%. They just don't have the reserve to get themselves out of these rhythms. So if you had a run of VTAC and you have a low EF, then you are more susceptible to cardiac arrest with that. Structural heart disease can do this, unexplained syncope, certain LV dysfunction, certain cardiomyopathies, and then if you've ever experienced a sudden cardiac arrest. The way most of these are put in, they're under the left clavicle. They can be under the right. Left is more common. And what they'll do is they'll actually make a pocket there. They'll access that subclavian vein. They'll put sheaths in there and run wires into the heart. They'll run their leads in. Your RV lead is your shocking lead. So that lead will go into near the septal wall, near the apex of the right ventricle. Then you'll have a lead put in the right atrium as well, if that's deemed necessary. If you're going to do CRT, then you'll actually go through the coronary sinus and snake a third wire around the back. Remember that coronary sinus actually sits on the back of the heart, and those where the cardiac veins feed into that. So what they try to do is place that small lead all the way out near the wall of the left ventricle. So now you can take somebody with a bundle branch block, and you actually shrink their QRS by synchronizing their heart. So you actually can, instead of the heart beating with left, right, where you get that swing like we talked about in bundle branch block, we actually can retime that to where the heart beats at the same time, both ventricles. And these patients will be pinker and feel better on the way back to recovery. So these are really remarkable devices that are out there. So when we talk about anti-tach pacing, what are we talking about? Well, here's a patient that gets themselves into V-tach, and we see this area right here. What's all that? We see those pacing spikes right there. This is anti-tach pacing. This is using refractory period, which we talked about in a previous video. This is using refractory period. They're trying to outpace the tachycardia to where when the next V-tach fires, everything is refractory. It can't respond to that, and then everything resets. We see that was result in this EKG. Another device you may see is sub-Q ICD. This can only defibrillate. It's not a pacemaker. And this is actually put on it's subcutaneous to where it's not inside the great vessels, inside that subclavian. It reduces the chances of stenosis and of infection. Patients who are prone to infections, a lot of times they'll have old systems taken out and this used to replace it. You can see that from the device that's kind of tucked under the lat or on the side there, goes over toward the xiphoid process, runs up along the sternum. Depending on the patient, certain parts of it may be more obvious in some patients than others. You'll see scars for different areas based on different techniques of implanting that. The cath lab I work, you'll see the pocket scar, and then you'll see a scar over the xiphoid process, and that's all you would see. The Zoll Lifevest is another thing we will run into frequently. And the Zoll Lifevest is designed to fill a niche there with the 90 days that we're waiting on someone who has had a heart attack to see if their ejection fraction is going to improve. And then we'll put a defibrillator in. So sarcastically, it's called the 90-day death test. If you survive 90 days and still need this, we'll get you one. Obviously, there's financial reasons why that's done. And you don't want to put a device in a patient and burden them with the money or with the small risks that come with a defibrillator. And so this kind of fills that void. So this is a defibrillator that's supposed to be worn by their prescription 23 hours and 45 minutes a day. So 15-minute supervised shower. The horror story from Zoll Lifevest reps that they talked about, lady on day 88. She's like, nothing's happened. Sends her spouse to the grocery store. I'll be fine. You just run on. Comes back and finds her dead. The only 15-minute period in 88 days that she was unsupervised by this, and that's when the VFib hit. So Zoll Lifevest it's typically pretty uncomfortable. Patients are always glad to get rid of it. But if they qualify for a defibrillator or their EF improves and they don't need one, then they can get rid of that. This is one that was in our cath lab. This fellow here, if you see the blue gel, you know that it treated somebody. This was a real nice fellow who was actually in the process of unbuttoning it to take a shower and passed out, wiped out the bookshelf in front of him, he said. But it saved his life. So ways EMS and ERs run into this at the interface that they have with ICDs. I remember getting called, your ICD is misfiring. Well, there's two reasons that it fires, and one of them is it's doing its job. So the ways you want to make sure you're doing that is confirm that EKG. If you put it on, the guy's like, I'm not passing out. This thing just keeps shocking me. And you look at it, and he's in V-tach. Well, then we can treat that and try to get him out of that. A magnet on top of a defibrillator will actually stop the defibrillation part. So I got a picture of that I'll show you, but you want to treat that arrhythmia. So if it's really doing its job, I'd leave it alone and treat the arrhythmia. If it's clearly a normal sinus rhythm or some rhythm that does not need to be shocked, and you watch it fire and hit this guy, then the battery over top of it will disable the defibrillation component. And that's what that battery does. There's an example of it. These are strong batteries. You'll see them in ERs. Pacemaker reps, defibrillator reps will have those if you're interested in getting those. But that'll disable the shock. Let's talk about permanent pacemakers. Permanent pacemakers serve as a lower limit for the patient's heart rate. So if it's set for 60, it won't let them go below 60. Typically, there are some small caveats with that it will, on a programmed mode, it will let it go a little bit lower to try to encourage that patient's heart rate from becoming dependent on that pacemaker. But for the most part, that's the lower limit. The patient can have a faster heart rate, and there's an upper track limit that the pacemaker will not continue to track and help support that. So if their atria goes faster, and the body's, hey, we're exercising, we need to go faster, then the pacemaker will pace right along with that, usually up to about 120. After 120, if it gets into AFib or SVT, it won't respond to that. It stops. I'm not going to contribute to the problem, and it stops pacing at that point, and that patient's heart can go faster if it still wants to. But the pacemaker will not support that over that upper tracking limit. There's what's called rate response, a mode in the pacemaker that can be turned on. This is used a lot I see it in different patients, but one of the reasons you'll see this is patients with heart transplants. So as they start to move, there's motion sensors built into this that'll actually tell it to increase, hey, we're getting ready to exercise, let's increase our heart rate. That's called rate response. Permanent pacemakers, typically if you have a sinus pause, you're going to earn yourself a pacemaker. You find out that P waves resist gravity. When the P waves go away, gravity takes over. So a lot of your syncope, a lot of your patients passing out and falling comes from a lack of P waves. So your pacemaker will prevent that. So some of your rhythms that you may end up seeing needing pacemakers, second and third degree heart blocks that you cannot find a cause for it, even your sinus pauses. If you can't find a treatable cause for those rhythms, then they're going to be heading toward a permanent pacemaker. Once again, same way as a defibrillator is put in, typically under the left clavicle, could be under the right. They'll snake those wires through the subclavian into the heart. Your RV lead, same place, it goes on that septal wall near the apex. You'll have an atrial lead. If you need the cardiac resynchronization therapy, they'll snake it through the coronary sinus around the back of the heart. Now, all a pacemaker wants to do is pace. So all the parameters you put in there are actually telling it when not to pace. So it will pace, and it actually has a blanking period put in there where it will shut its eyes so it can't respond to anything. And then it will watch again and reset a timer. So all it's doing is you told me that every so many milliseconds, there should be a pace in the area I'm responsible for. So that RV lead just sits and watches the RV for a pace. If the person paces one themselves, then it resets the timer and starts watching. If it doesn't come in the right amount of time, it'll pace, it shuts its eyes, and then it'll open it back up and reset the timer. So here's an example of the interrogation of a pacemaker. Here, the top channel is your A lead, and your bottom channel is your V lead. And here you see AS, VS. So that's A sense, V sense. So this is in, but it's not having to do anything. Here's atrial and ventricular pacing. So you'll see A pace, V sense, A pace, V pace. So it's just setting its timer. It knows that there should be a beat within so many milliseconds. It tells it what to trigger off of, and it will pace if necessary, or it'll just observe, it'll just sense and see that a beat came at the right amount of time. Here's an example of atrial pacing with native ventricular conduction. So it's A pace, V sense, A pace, V sense. So the sinus node is not working real well. So it'll fire, but it normally goes through the normal channels after that, the normal wiring after that, and it's able to pace itself. So the ventricular lead here doesn't have to pace, it's just sensing that. Now, at the point that the ventricles don't respond in time, then the pacemaker will take over. And then here's V pace only. So you'll see this sometimes on patients who have AFib and have had an AV node ablation. So when you're treating AFib, you try to get them out of it. You can do an ablation, but the longer AFib goes, the more the problem spreads across the entire atria, both atria, and you really can't treat that anymore. So one of the final ways to do that is to ablate the AV node, which is really the His bundle, but you ablate that, scar that to where the atria and the ventricles can't talk anymore. Make sure you put a pacemaker in first, but now you can actually keep that person from ever having irregular beats again. They won't have RVR with that AFib because it can't respond to that. And now here's just V pace on a nice steady beat. So that patient's breathing improves. They'll always be anticoagulated unless you end up giving them a Watchman procedure. The left atrial appendage occluder. We'll probably talk about that in another video. But here's a V pace only, and that's proven by interrogation. So what happens if you put a magnet on top of these patients? Well, this will actually put it in an asynchronous mode. And this is more of a surgical deal. You'll see this in patients where there's an emergency surgery. We don't have time to get a pacemaker rep here. We're going in for this surgery. You'll see them put a pacemaker over top of the device. Now, it won't respond anymore to all the artifact. It's just going to pace asynchronously at a set rate. And here, the three vendors that come to the lab I'm a part of, one of them does 65, one does 80, one does 85. So it's just a matter of what that's preset to, but a magnet on top of these pacemakers will just pace at a steady rate at a set time. All right, that's pacemakers and defibrillators. I hope that was helpful.